All right, so we're going to talk today about sleep apnea screening, post-discharge care to reduce readmissions. And it is always a tough place to be in the agenda when you're right after the first break that everyone rushes to the vendor area to see what's new. So I hope everybody had a chance to see some good things while you were there. Let's get through some of the session objectives. We're going to understand how and why to implement an OSA screening program in hospitals, understand the process to educate and coordinate post-discharge sleep testing and PAP therapy, and then the use of remote patient monitoring and remote therapeutic monitoring in order to prevent readmissions. All right, if we're not connected on LinkedIn, by the way, let me give something away here. Who's connected with me on LinkedIn? Oh, perfect. We'll give you a coffee mug right there. If we're not connected on LinkedIn, let's get connected. Please use your phone, scan the screen up there, the little QR code. Let's get connected, and we will share lots of great things about sleep together. I don't think I need to spend a lot of time really talking about the prevalence of obstructive sleep apnea with this particular group, because we all know the importance of OSA and treated OSA, that is. But isn't it funny how long we've been in this industry, and the number that has always sort of recirculated over and over? You want to go back to the QR code? All right. The number that has always recirculated is that 80% of patients still remain undiagnosed and untreated. And I have seen some updated information from ResMed recently where they actually quote 90% of patients remain undiagnosed and untreated for sleep apnea. So, we still have a lot of opportunity. This particular slide came from the Frost and Sullivan information. I wish they would update this because it's fantastic information as it relates to the sort of financial impact of obstructive sleep apnea and what it means. But for me, this slide means all of these different health conditions that sleep and sleep apnea play a part of. And I think that it's important that, every time we have the opportunity, we sort of preach the message of how impactful sleep and sleep health is for patients and just general well-being. So, we probably have heard the phrase that talks about the pillars of health. Well, I'm here to say that sleep is the foundation of the pillars, because if you don't have good sleep, then all of these other things are going to be absolutely impacted. You may be able to get away with maybe not exercising and still having some of the other pillars in place and living a long and prosperous life, but I assure you that lack of sleep and interrupted sleep is certainly going to be an issue in the long term. But tell me today, why don't we screen patients for sleep apnea? It seems obvious in a hospital setting that you would screen patients for obstructive sleep apnea, right? But does anyone actually have an active inpatient OSA screening program in your hospital today? For people at home, that is 0 in the room. So no inpatient screening programs. And I don't want to say that this presentation is more important than anyone's, but I think the content of this presentation is extremely important. And if you leave with anything here today, I hope that you will at least consider how to engage and start the discussion around screening patients who are inside the 4 walls of a hospital. Now, there are some barriers and challenges that are just sort of natural to our world, and it's always that these government agencies just never help us. So what do I mean by that? Last year, there was this U.S. Preventative Services Task Force that looked into should we be screening proactively populations of people for sleep apnea. Well, it was sort of inconclusive, I think. Ultimately, they came out with their recommendation, and it said, there's insufficient evidence to recommend for or against screening for OSA in the general population. What in the world? If we know that 80% of the patients are undiagnosed, untreated, why is it that the results of this particular survey showed that there wasn't a conclusive evidence to be able to promote these types of programs? Even though they actually state in that particular article that there are adverse health outcomes associated with untreated obstructive sleep apnea, including cardiovascular disease, cerebrovascular events, type 2 diabetes, cognitive impairment, decreased quality of life, motor vehicle crashes, and it's also associated with increased all-cause mortality. It can kill you, but we're not really sure if you should screen for it. Ultimately, where they left it is that clinicians should use their clinical judgment regarding whether to screen and how to screen for obstructive sleep apnea. Holy smokes. I bet they spent millions of dollars for that. Hey, but wait, there's more. There was a sleep survey that was done. This was really back, I think, sort of on the end, maybe on the heels of where COVID had all of our sleep labs shut down. And this was a survey that was sponsored by Itamar. But back at that time, it was that 89% of the respondents believe that they know what sleep apnea is. Isn't that interesting? So people know, they've heard about it, they have an idea of what sleep apnea is. 33% of the respondents did not know that they could reduce their risk for cardiovascular disease, diabetes, and stroke by treating their sleep apnea. So they knew about it, didn't really understand the all-cause health issues that could be impacted by having an untreated sleep apnea. 24% of the respondents did not know about the existence of home sleep testing. I bet that's probably changed today. If prescribed or required, 56% of the respondents would choose a home-based sleep test versus in-lab testing. I probably would too. Some of the top three concerns: sleep test costs were expensive. It's also inconvenient, and back during this time it was COVID fear. And then 25% of the respondents stated that they either were unaware that snoring could be a sign of more serious health issue or did not believe it to be true. Isn't that interesting? But remember, they knew what sleep apnea was, remember? And then 23% suggested they would think twice before seeking medical help for a sleep problem, with 28% stating outright that they would not seek medical care at all. So not only do we have these government-sponsored surveys that are sort of impacting our ability to implement screening programs, but we also have just a lack of patient education. But, you know, thinking through some of the numbers, again, 80% remain undiagnosed, untreated, 9 fewer years life expectancy for an untreated sleep apnea patient. Again, it can kill you. It's serious and significant. 209%, and this is the thing that probably surprises me more than anything when it comes to the payers, because I know that with payers, they don't want screening programs because it produces higher utilization of diagnostic tests. Right? However, higher than average per member per month total medical spend for Medicare beneficiaries with OSA, 209% increase in healthcare costs. So if we do have higher utilization, it will ultimately result in a lower cost of care. Now, I think this, you know, one of the things as I have seen some of these chronic care management programs that are out there today, and, you know, go out and Google search all of these different types of programs. I just picked out 4 that I found. They've got all of these different health conditions that they consider to be part of their chronic care management: heart disease, cancer, chronic lung disease, stroke, Alzheimer's, diabetes, chronic kidney disease. Not one of these companies, none of them, included sleep as part of their chronic care management of a patient. Interesting, right? I say that sleep has to become part of chronic care disease management for the long term of these patients. Can I get an amen? Yes. Now, I also wanted to find out, what does AI have to say about, you know, sleep apnea screening and as it relates to hospital systems? And it gave me a lot more content than I absolutely expected. And I know it's in really small type, so I broke it down for us. If you implemented a proactive sleep apnea screening in a healthcare system, offers several benefits for both patient and healthcare providers. Additionally, health insurance providers can also gain advantages from such proactive screening. What are those advantages? Benefits of proactive sleep apnea screening for a healthcare system: early detection and treatment, reduced health complications, cost savings, enhanced patient satisfaction, and improved quality of life. Those are great reasons to implement sleep apnea screening in a healthcare system, I think. To the health insurance provider, you know, what is that sleep apnea screening program, what's it going to do for them? Risk reduction, cost containment, long-term cost savings, enhanced customer loyalty, and data-driven insights. To me, these are all the buzzwords that you hear around you know, health insurance providers and the things that they're looking for. And I know that we can play a huge part in helping them to achieve some of those types of outcomes just with the things that we would normally want to do for a patient that we know is undiagnosed and untreated for sleep apnea. Did you get it? Okay. But how in the world do you get started with a sleep apnea screening program? I said this at a presentation a couple of weeks ago, and someone had never heard the phrase, how do you eat an elephant? So if you haven't heard it, how do you eat an elephant? One bite at a time. So you start with a high-risk patient population. So one of the things that I would implore you to do is, number one, don't try to start a screening program where you're trying to screen every single patient in the hospital. Because to Jerry's point earlier when he was talking about trying to prove the concept and justify the reason to implement a different type of program for your facility, you want to make sure that you sort of set yourself up for success. So screen a highly prevalent population of patients, do it for a short period of time, so that now you can take that group of patients that you have done stop bang screening on those patients. You can take that and then use that as part of the justification to show the prevalence that is within the four walls of the hospital that is undiagnosed and untreated. Is anybody here at a hospital system that has 1,000 beds? Not quite that big. Oh, so we've got one. Every time I have seen a successful program implemented in a hospital for identifying patients who might have obstructive sleep apnea, typically 25% of the patients at that moment are positive. 25%. So she potentially has 250 patients that are right there inside the four walls of the hospital that need to be seen in the sleep center. And we'll talk about what these sleep apnea screening programs can do for sleep labs in just a few minutes. But you want to take the results of the survey. So let's say that over the course of a 2-week period of time, you're able to survey 200 patients who have gone through maybe the respiratory ward or whatever department you choose in the hospital system. And there is a significant number of those patients, because remember with a stop bang, and my experience also is that in most programs that have these types of screening programs, most hospitals that have these types of screening programs, they typically can't use the same scale that we would want to use sort of in the outpatient setting of 3 or more positive responses. They have to use 5. And why is that? Because using a stop bang survey produces so many patients, they can't even get to the patient bedside to be able to do the sleep apnea education for those groups. The other thing, too, is that you need an influencer and a champion. You need somebody inside the hospital who's going to advocate for this type of program and understands the overall result of what this could do for patients, not only who are within the four walls of the hospital, but from an outpatient perspective to try to keep those patients from potentially readmitting in the future. So the next steps in the planning, once you've made your case for implementing a screening program, and hear me saying this, I know that this will get a little bit complicated as we sort of get toward the readmission reduction part of this presentation, but I do want you to know that you have to start with the sleep apnea screening first, okay? Stay focused on that piece, because you've got to implement the program. And then in addition to, so if you have Epic in your hospital system, my experience is that most Epic EMRs have a stop bang that is part of the patient intake process, but it's not mandatory. And if it's not mandatory, guess what happens? It doesn't happen, right? If it does become mandatory, who are the positive patient results going to go to? What department? Who's going to own that list of patients? And then what's the next steps for that patient group? So EMR must be mandatory. What are the stop bang thresholds needed to produce a sleep navigator visit? If you have daytime staff in your sleep lab and you have the ability to implement a sleep navigator program, it is the best of the best of how to deploy this program. And if that person is a CCSH and has the ability to really do condition-specific OSA education to that patient, then I think you're going to produce a better outcome in the long term, because that patient is going to start to tie the things that have them in the hospital at that particular moment with sleep apnea, so that they'll understand the importance of having it taken care of long term. I did get this question in the last conference that I spoke at about implementing sleep apnea screening in the pre-op area. Don't do it. Don't ever do it. Yes, there are patients who are undiagnosed and untreated, but I promise you, you will have the lowest capture rate of patients who will continue to stay engaged after they've had their surgery. Get them while they're in the hospital. You actually even need to sort of time when the education occurs for the patient, so that it's a little closer to them going home than it is the patient at the beginning of their hospital stay. Now, here's another potential issue. Does the sleep lab have capacity to free up to fill someone for that navigator role? And then is there capacity in the sleep center to actually even do the sleep test? Is anybody booked out longer than a month? Okay, we've got a few. Anybody have lots of open beds that you need to fill? Well, I see a few head shakes that they do have some availability. So if you are in a situation where your lab is booked out, then it is just my personal opinion that in order to free up bed space for these highly acute patients, you need to start triaging your orders when they come into the sleep lab. And if it's a non-comorbid, non-complex patient who could be diagnosed, and the potential issue for that patient is that we suspect that they have sleep apnea, then try to move that patient to a home sleep test so that you free up space for the patients who are going to come out of the hospital and they need expedited sleep testing for this particular program. Do you have physician capacity? I'm going to tell you the story of a hospital out in the middle of nowhere. It's a 36-bed hospital, and I think they have one of the best inpatient sleep apnea screening programs in the country. In fact, I stole one of their clinical protocols so that I could share it with you today. Home sleep testing device capability. I have had the opportunity to have conversations with different hospital systems where they'll talk about their home sleep testing. Even that is backlogged weeks and weeks and weeks. In some cases, I think the longest that I've heard recently was about 3 or 4 months for a patient to get a home sleep apnea test. Get more devices. They're not that expensive. Outsource your home sleep apnea testing so that you have a mail delivery option for patients if that's not something that's part of your current operation for your patients. Because ultimately, you want to make sure that you're able to deploy quickly and get patients diagnosed quickly so that they stay engaged with the process. So, really if you're going to highlight this program, what are the key components? So we want to screen and protect the patient. So we want to screen the patient while they're in the hospital. We want to protect the patient while they're in the hospital. We want to provide education and coordination of care post-discharge. We want to diagnose and treat, obviously, and then monitor and report. And we'll cover what that looks like in just a second. But as far as the screening, stop bang, I know there are some other EMRs that have some other clinically validated types of screening tools for sleep apnea that are part of their system. I think that if you just ask the question, are you overweight, do you snore, do you have high blood pressure, that would produce enough patients to keep your sleep lab plenty busy. But the stop bang survey, what that can do is at least identify, and for patients, maybe they're 3 to 5, maybe their responses are like 3 to 5 that they're positive. You then provide just education to the patients who maybe are at that 3 or 4 level, and then for patients who are 5 or more, they would get a visit from a sleep navigator. Now, if you are in a position with a hospital where you are thinking to yourself, there's no way we would ever get a sleep navigator justified to actually go to the bedside and do this education, we'll talk about how to potentially redeploy the program a little differently. But one of the things I think that is important too is that if we think it's important enough to put a armband on a patient for a fall risk, once we've identified that patient, why not put a wristband on the patient because we think that they might have obstructive sleep apnea and have desaturations and Brady-Tachy syndrome that occurs. My wife was an ICU nurse for years, and she remembers seeing Brady-Tachy syndrome in the sleep lab or in the ICU unit. And guess when it occurred mostly? During the nighttime when patients were asleep. I won't mention that I think there may have been a patient that got a pacemaker or two at some point during that, but without looking actually whether they had sleep apnea or not. But I think it's then also, now that we've put that wristband on the patient, so everyone who's part of the clinical care team for that particular patient will understand that there is a need to take care of that patient's airway. Because what if the patient's admitted for one issue and at some point has to go to surgery? Now we've also made it clear to the anesthesia department that patient needs to have their airway protected in the recovery room for a longer period of time maybe than a patient would who doesn't necessarily have sleep apnea issues. Now this is the thing that I actually stole from the hospital, the small hospital, is that they implemented an OSA protocol. To me, this is how you protect a patient who's within the 4 walls of the hospital without necessarily having to do an inpatient sleep study and even trying to do titrations, I guess, in the hospital. And by the way, when I get done with this presentation, if you have connected with me on LinkedIn, send me a message and I'll be glad to share my slides with you. But as far as this OSA protocol, think about these things. They're pretty simple. Elevate the head of the bed. Avoid supine position. Multimodal pain management. That means that the physicians need to think a little differently about how they manage that patient, because there's an issue potentially for that patient from an airway perspective. Maintain their SaO2 above 90%. Maybe they just need some low flow oxygen to help them keep their SATs up. I think just raising the head of the bed and keeping the patient off their back are two things that would be super helpful from an apnea perspective. In some cases, I've seen some hospitals where they have deployed continuous pulse oximetry or even end-tidal CO2 monitoring of some of their patient populations. Again, it just depends on the types of equipment and things and resources that you have in place to be able to do these types of programs. And then, lastly, if the patient absolutely needs it, then, they need to start CPAP and BiPAP while they're in the hospital. I'm a part of a program now where patients who are identified in the hospital, there are some instances where the physicians need that patient to go home on a device, whether it's CPAP or BiPAP. And the hospital pays for that patient's therapy until they can get on their payer-provided device. It's a pretty good program, and ultimately for a patient, let's say that they're early stage COPD, they have an exacerbation though, they go to the hospital, they're on BiPAP and O2 for a few days, they get better, and then we send them home and they haven't qualified for BiPAP at that point. So at least from that hospital's perspective, they are protecting that patient post-discharge. And no, it's not a billable service. They've just chosen to do the right thing for the patient. Coordinated sleep apnea care. The sleep navigator is going to go to the bedside. I mentioned providing that OSA or the specific condition-specific OSA education. I think when you can tie the patients, why they're laying there, why it is that they're laying there in the hospital bed in the first place, you tie that to this obstructive sleep apnea and really emphasize how important it is for them to follow up. To me, it shouldn't be an option for a patient it should be no different for them to do their pulmonary follow-up as it is for them to do their sleep follow-up once they've been discharged. Patient sleep assessment, completed next step. So essentially that sleep navigator is doing the things that are necessary to get the right documentation in place that you have sort of justified everything that's needed for that patient at discharge. And then essentially the order's created. And I have seen sleep navigator programs where there are order sets that are already built into the system, so it's kind of a click, 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 and everything's taken care of. But I've also seen programs where the sleep navigator is doing like half of the attending physician's work for them as it relates to sleep, so that the right things are created for that particular patient. Now, once they leave the hospital, again, we want to do expedited sleep testing on these patients. We want to make sure that we're getting that sleep testing done at the absolute first opportunity that we can get it done. And it might be that, hey, Mr. Smith, you're going to go home with your home sleep apnea testing device, but you can't do it today. We need you to do it tomorrow, or whatever the discharge period is that the patient has to have. And I'm not sure why that's the case, but I understand that there's a period of time where a patient, once they're discharged, before they can actually have an outpatient procedure performed. So you just want to know what that timing looks like so that they can get tested as quickly as possible. Once the patient has been tested and diagnosed, then you get with the results are reviewed with the patient. There's a PAP plan of care that's put in place for that patient, and then ultimately the patient goes on their payer-provided CPAP device or bi-level device. I know that there was a period of time when I was involved with a program, and the ER actually stopped doing blood gases on their patients on a regular basis who were coming in. There were COPD patients who were coming in. So that was one of the criteria that was needed in order to get that patient a bi-level device, and you don't have it. So now what do? Send them through a sleep process. So they probably are going to be intolerant of CPAP just by nature of how CPAP works for a patient who has COPD. And ultimately then you've proven that patient could need a bi-level device. So the patient needs to be enrolled, and I think that's why it is important to make sure you're working with a home care company. If you have a hospital-based sleep or DME provider, make sure that you have access to the programs that they are monitoring the patients in, so that you know what the data is. You want to make sure that program has sleep coaches, and also that they do resupplies. You heard somebody talk earlier about how nasty and gross a patient's CPAP machine was. You see all the pictures of CPAP masks with duct tape and everything. Resupply is a big part of making sure those patients are going to be adherent to their CPAP therapy. And then from a monitoring and coordinating standpoint, it is important to make sure that these patients are truly monitored not only by the home care company, but by the person who is responsible for that patient post-discharge. So we'll sort of move into the topic of being a lifesaver, if you would, for that patient once they're discharged from the hospital. So that with the goal of being to get that patient back into a physician office visit versus having them readmit because nobody's really watching the patient once they've been discharged. And then ultimately, you want to be able to track and report outcomes. And if I'm a hospital system, I'd love to have a program like this, show true success of keeping patients out of the hospital, and I'm taking that message to payers all day long. The sleep navigator, who is that person? It could be a sleep tech, respiratory therapist, could be a nurse. I think that you just have to look and see what the available resources are at your hospital. And then, ultimately, the CCSH, I know that's a big part of it. I am trying to carve out some time in my schedule so that I can get my CCSH. I know Jerry is probably trying to do the same thing so that we talk about it all the time, but we don't get a chance to actually go through and get the certification ourselves. Yeah, and then, that person is going to be the responsible party in addition to the DME of keeping that patient out of the hospital during that 30-day readmission or post-discharge period where the hospital could be penalized. You remember I called you a lifeguard a few minutes ago? This is where, now we've got this patient who's at home. Does anybody know what the clinical information is that you would get from a bi-level device for a patient once it's been dispensed for a patient in the home? Every day in your AirView, your Care Orchestrator, your React Health Connect software, what data are you getting every day? Yeah, is it effective treatment for the patient? He mentioned mask leak. Do you know what the bi-level you get? Minute ventilation, tidal volume, and respiratory rate every day on a patient who's been discharged from the hospital. That's great information. And there are clinical studies out there that show that a small increase in a patient who has COPD is a significant indicator that that patient's going to readmit to the hospital, right? By the way, I owe you a mug for answering. Now, I know that remote patient monitoring and remote therapeutic monitoring and chronic care management, there are different codes out there that you could utilize potentially with your within your physician practices, and that's what's interesting. The hospital cannot bill for remote patient monitoring. Did everybody know that? These are physician and provider-based codes, so it has to go through your physician practices. So my recommendation is that understand what the criteria for remote patient monitoring looks like. There are software platforms out there. I have no affiliation with this company, but there's a group called Monitaire. Monitaire has a platform that helps you. They receive data from AirView, Orchestrator, from React, all of the manufacturers, so that it helps you monitor all of your patient populations in a single platform. It even has a timer so that you are ensured that you've spent 20 minutes working on that patient in any given month so that you can bill for that remote patient monitoring visit. Okay? But essentially now we've got the lifeguard on duty who is that sleep navigator. Now, we've talked about a few things. On the home care side, I did mention this. Who's going to provide the PAP therapy? For probably the last couple of years, it's been who actually has CPAPs. Now that seems to have eased, and there seems to be more devices that are available in the industry. How are the patients going to be monitored? What system are, you need to understand the nuances of any one of the home care companies that you work with. What are the touch points they have for their patients? Do they have live support? Do they have sleep coaches? Do they have digital support for those patients? Some patients don't really want to talk to anybody on the phone, or do they have the ability to log into something and they've got all the resources that they need? And then ultimately, who's going to be the responsible party for that patient, both at the home care company and who's part of the Sleep Navigator program at the hospital? And then, what are I think before you really establish this post-discharge plan of care for your hospital system or a discharge plan for your hospital, you need to decide what are the metrics that help you determine whether it's successful or not. What if the only thing that happens is that you generate more revenue for the sleep lab because you are doing a whole lot of sleep tests. That's not a bad thing. What if you reduce readmissions at your hospital for patients who are being discharged? That's a great thing. So it is I think the very first time I ever worked with a hospital system, the administrator at the end of my sort of presentation, he asked the most important question, and I was like, oh yes, thank God. And his question to me was, how many sleep studies do we have to do to pay for this program? Easy. Easy. It wasn't that many, by the way. So I did want to talk about some of these. I've got a couple of examples I wanted to share with you, because you can implement this program in large acute care facilities, but you can also implement it in these smaller healthcare systems. There was this article in ormanager.com in their magazine about this hospital, Sauk Prairie Healthcare, and the 36-bed hospital that implemented a sleep apnea program. Let me tell you some of the complexities here. They don't have a sleep doctor, but they screen all of their patients for sleep apnea. What they did dedicate was a group of people to manage their sleep lab, so they do have clinicians who are part of the sleep lab. They dedicated a nurse practitioner who sees all of their sleep patients. So they have a great sleep clinic. In fact, I reached out to her to try to talk to her and sort of interview her to get a sense of how their program worked, and she couldn't talk to me. But the things that they have done here, a total of 3,000. Now, they started their program, by the way, in the pre-surgical unit. And then they sort of looped back and found that, hey, we think there's such a high prevalence that we need to actually screen in all of our clinics. So now they screen for sleep apnea for new patients who are new to these clinics in their physician practices. But a total of 3,985 surgical patients were screened, of which 94.9% had a preoperative assessment completion rate. They got almost everybody. Of those patients, 74% went on to need the OSA protocol. Holy cow. They screened 95% of their patients. 74% needed this OSA protocol to be implemented while they were a part of the hospital system, whether it was a procedure or whether they were an inpatient. And let's see, 70%, 26% of those who had the orders placed were required to spend the night using CPAP. So not only did they capture a lot of the patients screened positive, and then 26% of those patients were significant enough they had to put them on CPAP while they were there. Do we have sleep apnea in our midst? Big time, right? You know, a strange topic, completely off topic of this, but I keep hearing all of these things about the semaglutides and GLP-1s that are, potentially impacting the long-term patient population who might need sleep apnea. That could be the case at some point where we're all skinny and none of us has sleep apnea, but that's not today. Here's another, and Christina Weaver is a good friend of mine. She implemented a program down at a hospital parish healthcare system in Florida, and she used to be on the regular speaker circuit talking about her program. And what was interesting at that time, it wasn't just a matter of, hey, let's protect our patients while they're in the hospital. Her program was specifically designed to reduce readmissions. And you can see 30%, they had a 30% reduction in readmissions for newly identified sleep apnea patients over the last 4 years. Now, when I initially engaged with her and started having some conversations to learn more about her program, I was really surprised to learn, because I thought, man, they've got to have this sophisticated EMR and they've got all of these data reports. Her entire program was run from an Excel spreadsheet. But it produced better outcomes for their system. And she was so successful with their sleep program. She's been promoted now, and she's over multiple departments in the hospital, and sleep is just one of the things that's part of her responsibility. And she started her career as an EMT, by the way. Think about the impact that you would have at your healthcare system if you were able to implement a program that identifies these patients, you protect the patient, and then you put a plan of care together for that patient post-discharge that will help the hospital to reduce readmissions. And where did it all start? In the sleep lab and working with patients because of their sleep issues. I told you that I would also, and I'll try to go through this quickly in case there's any questions, but there is another way to do this without a sleep navigator, because I had the opportunity about a year ago to talk to a healthcare system that is really in sort of financial they're in poor shape financially as a healthcare system. And the medical director of the sleep lab said to me, I love this program, but we have no resources to implement a sleep navigator. So how could we potentially do this? When that is the case, this has to become it has to become a discharge program. Every hospital has discharge planners, right? I think it's also a risk management program for the hospital. If you have risk management that's part of your healthcare system, take this program to them. And when they have to develop goals for next year, one of the things could be making sure that they're not putting patients at risk who potentially have undiagnosed sleep apnea, who are there in the hospital at that very moment. But we sort of pare the program down to screen and protect, diagnose and treat, and then monitor and report. What does that look like? So I wanted to put just a quick timeline together where a lot of the major components are built into this timeline. You still got the stop bang survey on the beginning, still put a wristband on the patient, and I'm telling you, put that wristband on the patient. Make that part of this whole implementation of the program, because you want it to be that every person who comes in contact with that patient from now on has an idea that, and they understand, maybe they don't know what sleep apnea is. Maybe that's something you can also provide is some education on sleep apnea, or have the medical director do some education for the physicians on sleep apnea, so that they understand that now we've got this new blue wristband. What's that all about? Blue respiratory, by the way, I don't think there's any blue wristbands that are in use today. I could be wrong about that, but at least when we were first looking into developing the program, it was blue was available, so use blue. And then again, it becomes a part of the sleep discharge plan for the patient. So all of that education, has to really become digital in its format. You want to make sure you're providing information for the patient. And essentially it's, hey, you have a follow-up appointment with your pulmonologist on the 15th. You're going to be seen in the sleep center, prior to that, or you're going to be seen by a sleep specialist prior to that. Here's your appointment date for the sleep specialist. So let it just become part of that patient's natural discharge plan from the hospital, so that they don't really question why is it that I'm going in for a sleep test. There's even the ability in some cases, and again, I work with that one hospital that they pay for a device for that patient post-discharge. Now, if the patient has the ability financially to be able to cover the cost, then the hospital just coordinates that with the patient, but that is an expense that particular hospital has taken on. And I think that if your hospital has a DME as part of the system, there are some things that you could do creatively to make that happen for a patient at discharge. Expedited sleep testing post-discharge. You want to make sure, again, free up capacity in your sleep lab. Triage your patients who are on your sleep schedule if you're backlogged. If you have openings, this is going to fill your openings. You're going to need more staff. I don't know where they're going to come from because there's no sleep techs anymore, but that's another thing. I did look around the room, and I think Robert talked about the ages of some of the folks who are in here, and I count myself among you who have developed some gray hair over the years, but it is a shame that we don't have a bunch of 20 and 30-year-old people who are in here with us, right? We need to advocate more for our profession and get people, even though there's all of these technology things that are coming to the, that are on the horizon for us from a sleep testing perspective and that sort of thing, it's still not going anywhere for a long period of time. And I say, advocate, educate, and get more sleep techs. For these patients too, treatment plan is ordered, the PAP setup completed. That's the payer-provided unit. Maybe the patient's been on their loaner device or their bridge device to get them to their payer-provided unit. You still got the PAP support that needs to take place. You're monitoring and coordinating, and you're tracking and reporting outcomes. So you essentially just had to do away with the, that sleep navigator who's going to the bedside. And then, again, making sure I loved this OSA protocol. When I first read this article, I'm like, oh my God, this is to have an actionable protocol in place for a patient who hasn't even been diagnosed with sleep apnea yet, but we just suspect based on their own attestation that patient might have sleep apnea. This gives us something that that we can use as leverage as to why it's important for hospitals to do it, and now we've got a plan to be able to protect the patient. Because I do know I've seen hospitals push back because they didn't want to screen a patient and then not be able to diagnose the patient as quickly as possible, or have a patient who potentially has sleep apnea that they are aware of potentially and who is there in the hospital. Questions? I didn't do that good a job. You know,
please restate the question for the people online. Sorry to interrupt.
So her question was, if a hospital system has implemented a COPD navigator, you know, as part of their system, and they're still sort of waiting for the results of what that looks like to see if it was successful in order to potentially justify the need or the use of a sleep navigator at some point in the future. I will tell you, every program that, you know, I give you this sort of pathway, and it seems like, oh, that seems, you know, seems obvious that those would be the normal steps. But I'm telling you, every program is different. And if I were in your shoes, just hearing high level what you just described, I would want that COPD navigator to actually, I would want to implement the stop bang, have the COPD navigator include sleep apnea education as part of her responsibility, and then send them to the sleep lab so that we can take care of the rest for that particular patient. So there's not an easy answer. And even looking at what the success of a COPD navigator and what they judge as successful is going to be very different than what a sleep navigator is going to do, which is potentially produce a lot of volume for the sleep lab. Andrea Ramberg, who is the past president of the BRPT, she was a sleep navigator at a huge program up in Illinois, and the results of her activity by herself as a single sleep navigator produced 25% of the sleep studies in the sleep lab. And they had 11 beds. That's a lot of sleep studies. So you can tie revenue directly to a sleep navigator's role, which is a little less complicated than a COPD navigator. I don't know that I answered your question. But every program is going to be nuanced based on the dynamics that are at play within the hospital. No other questions? All right. If you connected with me on LinkedIn, or if you want to get a card and talk about inpatient sleep screening programs, I'm happy to do that with you, and love talking about it. So thank you all very much.